Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. And today I have an episode that I'm very excited about. Today, hopefully, I will learn and we're all going to learn what to do when patients present to the pediatric emergency department with what I call primary care like complaints. Stuff that we know don't represent anything emergent, serious, or surgical. Yet those patients are our patients. Some parents are very anxious about those situations. And the more removed I am from my general pediatric residency days, the more I forgot what to do with those patients. Stuff like the baby who spits up and looks great otherwise, the patient with abdominal pain that is chronic and has no red flags. So to do that, I asked Dr. Noah Makovsky, a friend of mine who does primary care in Colorado, to come and discuss those situations exactly. So, welcome, Noah, to PEM Rules. This is something that I wanted to do for a long time, and I know you're busy, and I appreciate you making the time. I'll introduce you very briefly because you're like a familiar face in PEM Rules by now. Noah is a primary care physician in Denver, Colorado, who happens to own his own practice. Okay, and how many people work for you seeing kids in Colorado?
Providers, we have 18.
Wonderful. It's a lot of work, a lot of children. And if you listen to PEM Rules, you could have heard Noah in episode 59, where we discussed the relationship between PEM and PCPs, and episode 86, when we discussed what to do when emergencies present to the PCP office. And today, I would like to take advantage of Noah's knowledge and experience and talk about what do we do when kids present with mild or chronic or non-emergent complaints, which happens all the time. And the problem that I found myself experiencing is the more removed I am from residency and my general pediatrics days, which is really limited to clinic in residency, the more I forgot about what to do for those primary care like complaints. So people come to the emergency department for several reasons, many reasons, and sometimes it's for true emergencies or urgencies. But let's be honest, the reality in the United States today is that a lot of kids don't necessarily have good access to primary care, or the parents kind of misinterpret the point of the ER, and they come to the ER with what I call primary care like complaints, which I fully accept. It's part of what I do. I did my general pediatrics residency in primary care. So I'm always happy to see those kids. I don't encourage people going to the ER for those kind of things, but I'm happy to see them when they're there. And the problem that I faced, that I noticed a few years ago, is that, again, the more removed I am from my general pediatrics days, the more I've forgotten about how to manage those kids. And let me just kind of briefly explain, Noah, so you can understand where I'm coming from. If you come to the emergency room with abdominal pain for 2 or 3 days, and it's in the right lower quadrant, and you're vomiting, and in your exam you're unable to jump, and you have what I think is peritoneal signs, I know exactly what to do. That's super easy. But when a child comes to the ER with abdominal pain for months, I think about and I check for all the red flags, and every chief complaint has red flags. So, for example, if the child is losing weight or vomiting green stuff, I can take care of that. But many times, very often, it's abdominal pain, which is just an example, for many, many months, and the child is otherwise well, goes to school, comes back from school, no red flags. And in those situations, I want to be careful and not sound dismissive to the parents, but I know there's no emergency and I'm not sure what to do and how to help those kids. So the purpose of today's episode is so you, as a primary care who see those kids, can maybe give us PEM physicians some tips on how should we approach those kids, and is there any workup that you do recommend we do in the ER, although it's not an emergency. I'm happy to do that and get the child started. Hopefully they can follow up with the primary care. So that's really the purpose of today's discussion. Does that make sense?
Makes sense to me. I'm ready.
All right. So first presentation, again, something I see all the time. Parents come in with their newborn and say the baby is spitting up nonstop. So again, very easy for me to first off rule out any emergency. So I always tell the parents about the white rule. Whatever your baby is spitting up has to be white. Anything green, anything bloody, you have to be very, very careful and very worried. And I always ask, sometimes I can even check myself, is there any concern with regards to weight gain? Certainly failure to thrive is something that scares all of us. But if the baby is spitting up white stuff, and I can see from the growth chart or the parents say, no concern with weight gain, I know there's nothing emergent. Now, over the years, I know there's, and I forgot most, if not everything about it. There's this formula and that formula. You can give Pepsid, you can give Prevacid. There's a lot of options. What do you recommend we do with those newborn babies who come to the ER with chief complaint of spitting up? They're totally fine otherwise. What's your approach to those children?
Well, we do see those children quite a bit as well. So I'm glad you bring that up, and I'm sorry that they make it to the emergency department as well.
We call it job security. It's all good.
Agreed. But I think, our job would be very similar to yours, and I would hope that it ends the same way, which is we do need to just head first. You got to approach the patient every time as maybe they do have something that is a real problem. My job is to make sure I'm not missing the needle in the haystack. But as long as I'm not, then ultimately the idea of being very supportive of the family and making sure that they understand by educating them that some of what they're seeing or experiencing is just normal is okay. And I'm amazed, as I've been doing this now for quite a number of years, that it's okay to end the conversation that way. And I have many families and parents that are so grateful that there really is nothing wrong. That's all they want. Earlier in my career, I used to feel like, okay, they came in, they paid a copay, they're spending their time, they need or they expect something out of this. And what did I think as a young, naive doctor at that time was they needed a prescription or they need something tangible to be able to feel that we've taken care of their issue or their problem. And that's just not the case. Many, many times they just need reassurance. So we have to have confidence in ourselves that we aren't going to miss the needle in the haystack. But as long as you go through, as you were pointing out, some of these issues, this is a kid who's thriving. They're growing great. They are happy. Yeah, sure, they spit up, but when they spit up, they don't care. They're smiley. They're happy. It's no big deal. It's white, as I usually tell parents. I'm like, do you recognize what's coming out of this kid's mouth? Like something that went in it not very long ago? Or is it something you've not seen before? Because if that's the case, I need to know. I ask them about their spitting up. If it is kind of dribbling out of their mouth, or I think I may have said this to you before, but like a waterfall, I'm generally okay. If it's shooting out like a fire hose, we better be talking. And so it's things like that that I bring up with the parents. And if I can check off my list and realize they don't have any of these big red flags, giving them the reassurance, I'm amazed. Most of the time they walk out, they feel great. And I think that PEMDocs can do the same thing. I think it's fair enough to say that I feel very good about this, but you should probably go see your primary care pediatrician just to make sure that everything continues on, your child continues to grow is wonderful. Because the advantage we have that unfortunately you guys don't have is that we see these people all the time, right? We have relationships. So when I say to them, I feel good about this, I'm not saying it doesn't mean something when it comes from you, but it might mean something a little different because we've built up this trust over time that may not occur with the PEMDoc if it's the first time they're ever seeing them.
Excellent. So what I hear you say, Noah, basically is, and I'm totally fine with that, is, do your anticipatory guidance, but most of the time in terms of intervention, less is more.
I agree. Absolutely. Less is more.
Perfect. Now, let's say, again, and this does happen quite a few times. The frustration is really great. They have been to the primary care. The kid is still spitting up. In terms of any intervention, what do you guys primary cares recommend as first line, second line? I know there's a lot of anti-reflux medication. To my understanding, they don't do anything for the physical reflux, just the acidity. Is there one that you guys recommend more than others? I know as a parent, I was told to thicken the feeds. Is this something that we still recommend? So if there is an intervention, what should it be?
Sure. Well, I mean, when it comes down to medication, typically I will make sure that parents understand these are antacids. These are not anti-spit up medicines. Occasionally, you give your kid one of these medicines and they don't spit up as much, but that's not what they're designed. And so we need to level set the expectations. And typically speaking, that often calms things down and allows me to say, I just don't think giving your child the medicine for this is going to help. But if there is some push or there's some feeling that the parents are saying, well, I know my kid looks so happy right now, but there are times when they spit up and they're really miserable. And I'll say, okay, maybe we do need to talk about a little medication. I almost always start with famotidine. And under 3 months, it's just a Q-day dosing. Over 3 months, it's BID dosing. It's a pretty safe medicine. And, I personally don't remember a kid I've had to take off of the medicine because they had an issue or a side effect. And certainly it can be helpful. Now, there are those kids, if they've got serious reflux, or I should say, acid reflux, where famotidine may not do the trick entirely. We might need to go to a PPI. But I do think that in general, and it's usually covered by insurance, it's probably the best place to start if you really need to do something. But the good old just, reflux precautions. It takes a few minutes to talk to parents about that and making sure that they're keeping their kid upright, even though you acknowledge that's going to be a real pain after you feed your kid, that you got to keep them up for 15, 20, 30 minutes, but use gravity in your favor. Those kinds of things are still really, really helpful. And it's okay to emphasize that it'd be great to do that instead of giving your child a medicine if you could get away with it. And I think that more and more, at least in my world, I see more and more families, they'd rather shy away from medicine unless they feel very, very desperate for things. But I think that's generally how we start that discussion and that approach.
And thickening the feed is not something
Yes.
you guys recommend anymore?
I'll tell you, I don't really do that very often anymore. It
Mm-hmm.
is something that I used to do quite a bit early on, and it felt like that's what we were taught in residency. Um, I don't do it very often at all. I don't see a lot of my kids who end up seeing Pete's GI come back with thickened feeds. So I think it seems like it's falling out of favor, probably because it wasn't really doing all that much other than clogging up nipples in bottles, and then kids are struggling to take the food in, and then they get upset for that reason. And that doesn't help. So I don't do that very often.
Excellent. So again, perfect. See, that's exactly why I brought you on the show, because I guess I'm stuck in, the 2000 when my kids were babies, and I think at some point one of our kids was a little spitter, and that's what was recommended. So perfect.
You're lucky. My kids think I'm stuck in the 70s, so you're lucky.
Well, I would say I'm a little younger, so I'll take that. Second thing, Noah, that again happens all the time, and school is about to start. It's going to happen more. Is the child who presents to the emergency room with abdominal pain for weeks, sometimes months. And again, from a PEM perspective, I do think about ulcerative colitis. I do think about Crohn's disease. My experience with those conditions, there's always some, if not many, red flags. There's almost always some weight loss. The kid looks pale, is anemic, family history, maybe some other autoimmune diseases or some other problems. But very often, most often, it's a kid that just has abdominal pain. It's not in the right lower quadrant. There's no vomiting. Gotta be honest, it happens more on Monday morning, etc. The exam is normal. And again, this probably is just chronic abdominal pain. And anything that is chronic, not in a dismissive way, is not exactly what I do. So a kid who's had abdominal pain for months probably doesn't need a CT today. Again, the CBC, maybe there's anemia and this and that, but for the most part, I try very carefully not to sound dismissive for those kids. But if this is abdominal migraine, I don't know what to do. If this is school avoidance, I certainly most definitely don't know what to do. So what is your approach to those children?
Yeah. Well, I think somewhat similar in that we have to make sure that the family and the child does not think we're being dismissive. And
Right.
I really say that seriously, because if they get that sense very early on, you're not going to get very far with it. Even if you know deep down the answer is this kid's got anxiety because he's only got a stomach ache on Mondays. If you start with that, it's going to not go very well. This family and this child's been dealing with it for a long time. So I just think rule number one, always take the child and the parent seriously, even if you know deep down that it's probably not a serious concern.
I agree 100%. Yes.
Yeah, I think
easier said than done sometimes, but absolutely.
Yeah, of course it is. And if you're really busy and you've got really sick kids that are next door, it's pretty hard to do that. But I think it's an important thing to at least strive for. I think that number two is similar to what we said a moment ago. You still have the obligation to try to make sure you're not missing something more serious, because just because they've said they've had a stomach ache off and on for the past 6 months doesn't mean that today they don't have a new presentation of something serious. And that is important to just make sure that it's at least thought of. Then I start thinking about some of the things that can cause chronic abdominal pain that maybe aren't terribly serious, but at the same time, they're relatively common, and there are things that we should be recognizing, doing something about. Certainly, number one on the list is constipation, which we know it exists. It's out there all the time, and a lot of times we don't deal with it the way we should, because if we could just make these kids feel better, and we do it before they end up in the emergency department or the next time they end up in the emergency department, and now you got to give them an enema and it's a miserable experience and all of that, we could have done them a lot of good by recognizing it, by asking a few more questions, by pushing the kid and the parent a little bit more, even if they squirm, they sort of think it's strange that you're asking them questions about pooping and all of those things. But if you do it, and all of a sudden you're like, all right, that's where we're going. Let's talk about some Miralax here. This isn't the end of the world. It can make a huge difference. We talked about reflux in babies. I see a lot of kids that I'm amazed that have, whether it be reflux, gastritis, whatever you want to call it, that they actually can do a lot better if you try them on a little bit of an antacid. And again, famotidine is not a bad idea to consider if you're really suspecting it through some of the history that's there. I think at the end of the day, if I don't figure out anything, and I think that the problem really is, call it mental health, behavioral health, anxiety, something like that, I really do my best to try to talk to the parents about that, and the kids, see if I can get them some help in that realm. But I will always end the conversation with saying we need to follow up unless it gets better with us going down this road, because I have been fooled. I mean, I've had kids who've come back, a month or two later, and finally we decided to do some blood tests and they've got celiac. And it wasn't the obvious presentation of an absolute miserable kid every time they had gluten, or they actually look okay on their growth chart. And sure enough, they've kind of been struggling for a long time. And now we finally figured it out. And frankly, I feel bad when that happens. It may have, sometimes those are just insidious cases. It takes a while to get there. But I have that advantage, of course, again, in my world as primary care. But as a PEMDoc, I think it's okay to say, listen, I don't think there's anything serious. I think this may be something with anxiety, but there could be other things here. This is actually a really important one to make sure you have a follow-up with your primary care. You should set up an appointment, make sure they know you're on the same page so that we can now have the long-term follow-up there. I think it's really, really critical, because we don't want to miss some of those very, very unlikely but possible cases that we could really make somebody better.
Excellent. Just so since we're on the same topic of abdominal pain, what is your criteria and how do you diagnose or even treat abdominal migraines? What do we do with those?
Well, I would say that abdominal migraines are very rare. At least I believe, in the years that I've been doing this. And I would say that I myself will probably not diagnose an abdominal migraine. To me, that would be a diagnosis that probably has to come from a neurologist, because it's rare. I wouldn't want to, let's say, kids complaining, and I'm going to put them on amitriptyline for a daily prophylactic, because I think that's what's going on, when I know that medicine has got lots of other side effects and things like that. And and I may be overshooting by using a medicine like that in this example, but to me, it's a diagnosis that should be recognized, but it's rare enough that I wouldn't go down that path without trying to get a specialist involved. The problem, of course, is access. I mean, it's just so hard to get into a neurologist. That's a tough one. So that might even be a phone call for me to a neurologist and say, I feel like I've ruled out everything. I really don't think this kid's got just, run of the mill anxiety, keeps complaining of this abdominal pain. GI's seen him. We're not getting anywhere. I don't know. It may be abdominal migraines. What do you think? And that's probably what I would do before I just went down that road alone.
Very good.
Yeah.
And along the same line, the kids, the children, usually teenagers, sometimes younger, who come to the emergency room with a headache. They've had intermittent headaches for weeks or months. And again, something that I'm very familiar with the red flags. So they don't have headaches in the morning only. They don't have early morning emesis. Their neurological exam is completely normal. No papillary edema, maybe some family history of migraines. And I'm pretty convinced those have tension headache or migraines. What's your approach to those children? So I can tell you I'm very good in giving a migraine cocktail in the emergency room. The combination of NSAIDs, antiemetic, and fluids can really make wonders. But what should I recommend for those children after discharge? Is there anything you recommend we start them in the emergency room to kind of prevent those? Any specific anticipatory guidance you recommend we give? What do you think?
Well, and we see obviously plenty of kids with ongoing headaches as well. We do the same thing, just trying to make sure we're not missing any of the red flags. I do think that these kids always need some kind of follow-up. So that's going to be number one. You're going to have to go see your primary care. I think telling them to keep track of their headaches is a very important thing to do. Some little journal or put it in their phone, have the parents involved in that. They don't have to write a whole story, but just so that we've got an idea of what's the frequency of these headaches, what's the severity, are there any triggers? I'm amazed at how many people come to see me who've had headaches for months and months, and they have nothing written down about it. So that would be really helpful to us. Number two, and I've learned this by sending lots of kids to the neurologists over time, and they see the headache clinic specialist, and I'm amazed at how much time they spend on just regular well-being, health, hygiene, making sure you're sleeping enough, making sure you are eating and not skipping meals, making sure you're well hydrated, making sure you are not on screens all of the time. Those kinds of things, which don't take very long to say, but to indicate to a family and to a patient that, you could really probably take some pretty good control of your own headaches here, but you have to do these things. You have to take good care of yourself. And if you're just not doing that and you're not being honest with yourself, it's not going to get you very. So I think that's really important. I think from a medicinal standpoint, again, it depends on how frequent they're having headaches, but first line, we'll usually just tell them, let's start with some ibuprofen. You want to get it on board as quickly as you can. Sometimes we'll add a little Benadryl, particularly if they have an opportunity to go lay down in a nice quiet room or at home, dark room, something like that. That can be very helpful. If we feel very confident that these are kids that are having migraines and we don't think that anything else is going on, we'll go into some of the triptans and maybe give them not a huge number, but some small numbers of some rizatriptan or something like that they can make sure they understand how to use this to see if we can abort these headaches or migraines if we believe that's what it is, so they don't really spiral out of control and they don't end up in the emergency department. We rarely get to the point, I believe, or at least I don't get to the point of putting these kids on a daily prophylactic, again, unless I have consulted with a neurologist, whether they've seen them or whether I've spoken to somebody, so I can feel pretty confident that that's the right road and that I'm not just covering something up that could be a bigger deal, even though it's extremely rare. So I wouldn't really expect that to happen in the emergency department. But I think, I don't know what the comfort level is if you ever send out kids with a little, rizatriptan or some Maxalt, something like that. I think it's not an unreasonable thing to do if you feel okay, more so to just get them to, let's say, the next appointment with their primary care. I think that would be something to think about.
Excellent. And just so, and you kind of mentioned it briefly, I think I spent a lot of time with those children talking about the cell phone and the screen time. I imagine that's something you guys um, do as well. I'm curious to know from your standpoint, do you ever see kids that have made that change, reduce screen times, and actually do get better? Is that a thing?
Yeah, it is a thing. It's very difficult. When I do see kids that come back and they've really made a change like that and they feel better, I mean, I give them all of the credit in the world because the pressures to be on their screens and on their cell phones is so great right now,
Hmm.
that takes a lot of strength on their part to do that. But I do see it. I mean, I think that the screen life that these kids are leading is not helping at all, and they spend half their day just in school on screens too. So it's worth bringing up and trying to encourage, not push them, don't make them feel bad, let them know we get it. This is the way the world is, but see what you can do. You cut it down even a little bit. You will probably feel better. I think that's it's worth mentioning. It's not just blowing hot air because we're going to say the same thing, so they'll hear it over and over again, which might actually sink in at some.
Excellent. No, this was actually really, really helpful as I suspected, and the list of primary care like complaints coming to the ED is ever so long and probably growing and probably going to continue to grow as the system becomes more saturated and more loaded. So I truly appreciate those advice. We're probably going to have to do this again at some point in a few months because there are going to be more chief complaints. Thank you very, very much for your time. As usual, and I came prepared in advance. The guest get to choose the outro, and I'm trying to prophylactically, be aware. You like Uncle John, you like Billy Joel. Those are never going to happen. I apologize. Piano skills are not nearly that good. But recently, I did come across a music video by the Beatles, and when you came on the show last time, we did "Let It Be" on the
Yes,
piano,
yes.
and that video actually had George Harrison playing the solo of "Let It Be," which is a great solo. So it took a few days. I got the solo down. So we're gonna do "Let It Be" with a guitar solo.
Perfect. Thank you very much. Appreciate it.
Thank you very much, Noah, and hopefully we can do this again. Have a great, great day. And that is it for today. I hope you learned from Noah, his knowledge and his skills. Again, something that has been challenging me in the pediatric emergency department when kids show up and they're not particularly sick, they have chronic illnesses, something that I don't take care of very often, and got some advice. So thank you, Noah, for coming on the show. Thank you for listening. Please check out the website, check out the revamped Facebook page, and write to me about anything you want to hear whatsoever. Appreciate you listening. Have a great day.